Good morning. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. We are doing our second day of industry clinical trial updates, and we do this twice a year. Yesterday was were presentations for patients, and today our presentations will be going out to physicians that see MPN patients, some of whom are MPN specialists. Of course, they will see this eventually, but also to those that are seeing MPN patients. Some are specialists, cardiologists, anything, other physicians, primary care physicians, anyone that does see an MPN patient. We have a huge silo in our database, and we try to make sure that they get this information. So today it will be for physicians, and we will hear from several of our industry partners, and this was recorded, so it will be available after today via recording, and we'll send that out, and it will also be available on our website and our YouTube channel. So without further ado, I'd like to introduce our first presenter, who is from Insight Corporation, and her name is Peg Squire, and she is the VP of U.S. Medical Affairs. And Peg has been with us before, and we're glad to see her. And Peg, I'll turn it over to you. Thanks for joining us today.
Right. Thank you so much, Ann. And thanks to all of you. I'm very happy to be here. And I'm assuming you can see my slides. Excellent. So it's my honor on behalf of Insight to present the agents that we currently have in full clinical development for myelofibrosis. Just making sure that I can click to the next, there we go. So I'll be talking about several compounds today. Some are investigational, and of course, that means that there's no guarantee that they will be ever be commercially available for these indications. But of course, ruxolitinib is commercially available. And what you see on the slide here are its current US indications. So Insight has a longstanding commitment to research in myelofibrosis, and we tend to think about myelofibrosis across the continuum of care. So as shown in this cartoon, we think about lines of therapy, which are shown from left to right, and we also think about patient subgroups within those lines, shown from top to bottom, including, for example, patients who have anemia, patients who have thrombocytopenia, and so on. And so for each of those different patient groups, we try to have therapies and clinical trials available. So as we go through, I'll be discussing each of these trials with more detail in subsequent slides. Okay. Our current primary focus is PI3 kinase delta inhibition with respect to late stage development. And I just want to take a moment to explain why. This diagram shows signaling in myelofibrosis. And of course, you can see JAK1 and JAK2 here with ruxolitinib. You can also see PI3 kinase delta. This is the dominant isoform of PI3 kinase in MPN cells, and it's known to be activated in these cells. It's also known that PI3 kinase delta can mediate JAK2 signaling, and it can lead to proliferation. And as such, it could mediate a potential resistant mechanism for JAK inhibitors. And we see preclinically that ruxolitinib and parsaclisib, which is our PI3 kinase delta inhibitor, can show synergy. And in fact, we see promising activity in the phase 2 setting in clinical trials in myelofibrosis, including patients who have been 6 months or more on ruxolitinib. So those phase 2 results have led to 2 ongoing phase 3 trials. This is the first of those trials. This is called LIMBER 304. Just to take a minute to explain the acronym, LIMBER stands for Leading in MPNs Beyond Ruxolitinib, which is our aspiration at Insight. This trial is in the suboptimal setting. So this is for patients who have received ruxolitinib for at least 3 months with a stable dose for at least 8 weeks immediately prior to enrollment. There's no washout on this study. These patients have to have at least splenomegaly of 5 centimeters below the left costal margin. They have to have symptoms of TSS of at least 10, demonstrating that they're having a suboptimal response to ruxolitinib alone. And so they add on parsaclisib at a relatively low dose compared to what it's been investigated at in other indications. This is 5 milligrams daily, or they add placebo. The eligibility criteria here are broad. Patients can, they continue their ruxolitinib treatment. Patients can have intermediate 1, 2, or high-risk disease. Patients can also have platelets as low as 50. And we also allow crossover on the study after 24 weeks of study participation. And we think that that should make this trial more attractive to patients and hopefully to study sites as well. Let's see. Okay, the second of our phase 3 trials is LIMBER 313, and this is in the upfront setting. So this is for patients who are JAK and PI3 kinase inhibitor naive. This is, again, a trial that we strive to make very broadly eligible to patients. Patients can have intermediate 1, 2, or high-risk disease. And we do require that they have splenomegaly or symptoms, but we try to make the thresholds as low as reasonably possible, and platelets can be as low as 50. We also do have a provision for crossover on this trial. Moving to our earlier phase of development, we have 2 agents that are in early development. The first is our BET inhibitor. Now, BET proteins, of course, are transcription regulators that bind to acetylated chromatin. These are of great interest for splenomegaly, symptoms, potentially anemia, and also other disease parameters in myelofibrosis. This is our phase 1 trial. We are investigating our BET inhibitor, INCB 57643, as a monotherapy and in combination with ruxolitinib. And this trial is currently for patients who have relapsed refractory myelofibrosis, also for patients with MDS and for MDS-MPN overlap syndrome. And then lastly, we have an ALK2 inhibitor in early development. ALK2 is a target of interest in myelofibrosis because of its ability to regulate hepcidin. That can potentially target anemia in MF. And so this trial is for anemic patients. This is, again, a monotherapy trial and also a combination trial, dose finding and then expansion. And as you can see here, for the broad eligibility, both for platelets and for anemia parameters, we again are hoping to make this broadly available for this patient subpopulation. So these are the trials that we currently have available in myelofibrosis. If you would like to get more information, or if you have a patient that you think may qualify, we would be very interested in talking with you. We have our medical information numbers here. The US phone number is here. We have the US and global email addresses, as well as our website for insightclinicaltrials.com. And I thank you very much for your attention.
That was excellent. That was a great overview, and we really appreciate it. And we appreciate the support that Insight has given us over the years. I mean, since way back when. And great things are happening. Thank you very much, Peg.
Thank you, Anne. Greatly
appreciate it. So we will be moving on to our next presenter, who is from Imago Biosciences. Hugh Reinhoff is the CEO there, and will be sharing information of what's going on at Imago. Hugh?
Thank you, Ann. Let me bring up my slides. Okay, hold on.
You'll share your screen.
Yeah, I will do that. Excuse me for a second. Apologies. Hold on.
You put your
Yeah, hold on. Yeah, just
down at the bottom to the right, almost to the middle of the screen, it says share screen. There,
Yeah.
it's green.
gotcha. All right, thank you. And do you see that?
Yeah.
All right,
Your
I
first
shall
slide up.
expand that into presentation mode. Thank you.
There you go.
Thank you, Ann. I've been a fan of yours for a long time, and Imago has been around for about 10 years. In fact, we celebrated our 10th anniversary on Monday. It was a company founded by myself, a hematologist, and 3 other very capable women, and we're now 37 people. Our lead program is a molecule called bomedemstat, which is an inhibitor of an enzyme called LSD1, which regulates hematopoietic differentiation, including stem cells, and all the way downstream. We are currently in phase 2 for the indication of essential thrombocythemia. That's a CTP 201, and we were almost fully enrolled in that study. And we've just completed the first 24 weeks in 89 patients with myelofibrosis, and both of those studies will enroll their patients into an extension study. And we're planning on a phase 3 study early next year in essential thrombocythemia. And I'll introduce the molecule. Bomedemstat is an irreversible inhibitor of an enzyme called lysine-specific demethylase. This is a molecule that we discovered and developed over these last 10 years. And it's a once-a-day capsule, and we dose on the basis of platelet counts. So we're able to bring patients' platelet counts into a target range, which is sufficient to tame the megakaryocyte, and of course, an ET and MF. The megakaryocyte is really the central cell acting in those diseases. We've been in approximately 170 patients now, but just to give you a little bit of background on LSD1, it is highly expressed in long-term hematopoietic stem cells, and it regulates actually the balance between self-renewal and differentiation. So we've seen in both animal models as well as in patients now an impact on the mutant allele frequency or the mutation burden that the hematopoietic stem cells carry. So I think that's an important feature of LSD1, its ability to regulate those malignant stem cells, and by inhibiting it, we offer the prospect of being truly disease modifying with respect to progression of disease, in particular to AML. So in the ET study, the so-called CTP 201 study, this is a global study, and these are patients who have failed at least one standard of care. And of course, around the United States, that might be hydroxyurea, it could be anagrelide. Around the world, it would also include interferon and busulfan and other agents. But most of the patients that enrolled in this study are actually hydroxyurea resistant patients who've had either intolerant signs and symptoms, or they are truly refractory to the agent. Obviously, the platelet count is the primary endpoint for this study, although the absence of thromboembolic events is another feature of the endpoint. And patients are started at a dose of 0.6 mg per kg, and then titrated to the target platelet count, which is less than 400,000. And you can see that as patients wash out from the previous therapy, their platelet counts do rise. So I would call that the baseline for their disease. And then bomedemstat starts to kick in around the second week or so. And by the 8th or 12th week, most patients are in the target range. And at a stable dose, they actually stay in that target range of less than 400,000. And the white count follows suit. You can see that, again, there's a little bit of a rebound during the washout period of white count. And even though most patients don't have an elevated white count, there are some that do, and it's an important second endpoint because elevated white counts or neutrophils in particular are an independent risk factor for thrombosis. And you can see that the white count is brought into the normal range. And as patients progress, they stay in that range. And I think one of the most important things about bomedemstat for the treatment of ET and for MF is that it does not have a negative impact on red cell production. You can see on the right panel here that most of these patients, even though they had quite a range of hemoglobins between 10 and 16, maybe even a little bit more, they have a stable red cell count throughout the course of this study. I think that's important. We see something similar, in fact, improvement in the hemoglobin in patients with MF. This is the side effect profile, if you will, the safety profile. We've been treating patients now for 5 years in both AML, MDS, myelofibrosis, and also ET. Dysgeusia, grade 1 typically is a major complaint. And I would say that's of the 130 patients that have been in the MF and ET study, only 3 have discontinued. It's a manageable hypersensitivity to taste, if you will. So you get heightened sweet sensation, that sort of thing, as opposed to the metallic taste that you see typically with chemotherapy. We've had a very small number of SAEs in this study, and there have been no safety signals in the last 5 years that we've conducted data safety monitoring committee meetings. When we look at the total symptom score, yeah, as you know, in ET, fatigue is the major symptom that these patients have, and their symptom scores tend to be lower than those with MF. But nevertheless, we see an important impact on symptom scores for patients. And when we look at the fatigue scores teased out of the TSS, the total symptom score, you can see that once we get these patients to a stable dose, which, as I said, is around 8 to 12 weeks, their symptom scores generally improve and their fatigue scores are responsive, as you can see. So I would just summarize to say with the ET study, the majority of the AEs were low grade, and the normalization of platelets is pretty much uniform across these patients, and their symptom improvement is satisfactory. Most of these patients have a symptom score drop of 10 points, which is what the ELN criteria recommend as a significant and clinically meaningful change. And all of the genotypes respond, CALRs and JAK2s, even though CALRs have higher platelet counts. All of these patients respond to bomedemstat. So our current study is still open, although I think we hope to have this enrolled in the next 2 months. And we are currently, as you can imagine, planning a phase 3 study. It will be a global study, as this one is, obviously more sites. And we expect to dose the first patient early next year. We've also used bomedemstat for the treatment of myelofibrosis, and this gives you a sense of the improvement in symptom score in these patients. It has a profound effect on many patients with much more severe symptoms than you typically see with ET. And with respect to hemoglobins, we also see improvement in those hemoglobins in these patients. And as you know, anemia is a major concern for many of these patients. So we're completing that study, and we will start a combination study with ruxolitinib. And we're very optimistic that we'll see both improvements in hemoglobin and spleen volume reduction. And another important component of the clinical response in to bomedemstat in myelofibrosis and also in ET is a decrease in that mutant allele frequency. And these are both the driver mutations, the CALRs and the JAK2s and MIPLs, but also the other mutations that are confer high risk to AML. And those include ASXL1 and EZH2. And AXXL1 seems to be the most sensitive to bomedemstat. And in this particular study of 89 patients where we've conducted it for now 4 years, we have not seen a single patient progress to AML. So we'd like to solidify that in a controlled study using bomedemstat. So I would just summarize and say we've treated 170 patients now across a number of different diseases with a good safety profile. As I said, we dose titrate each individual patient, so there's personal dosing, if you will, to minimize thrombocytopenia and anemias and to maximize the benefit of the drug. And as I said, this mechanism of action inhibiting LSD1, particularly at the stem cell level, offers the prospect of true disease modification. So I'll leave it at that, just saying that we will start a combination study later this year. We will also start a PV study later this year, and we will start our phase 3 study early next year. Thanks for your attention.
Thank you so much, Hugh. I love this information. I mean, it's so great to see the progress of these drugs over a lot of time, you know, and very happy for MPN patients. This is fantastic news. Thank you so much.
My pleasure. And thanks.
Have a good day. I'll see you. If we get questions, by the way, we will contact you individually if it's about your drug and your trial, unless we get them right now. But typically with the doctors, when we present to the physicians, we get information later from them because many of them can't be with us this moment.
Sure.
So thank you very much, Hugh.
You betcha. My pleasure.
We'll move on to AbbVie, who has joined us many times before with Brian Murray, who is the Assistant Scientific Director. Hi, Brian.
Hi, Ann. How are you?
Good, thanks. How are you doing?
Doing well. Can you see my screen? Should pop
Sure
up.
can. I sure can.
Great. And I will get started. Well, thanks, Ann. Good to see you. We met just yesterday at the patient edition of this conference, but thanks for your time. Thanks for giving me a chance to present an overview of AbbVie's activities in myelofibrosis. My name is Brian, as Ann mentioned. I'm an Assistant Scientific Director, U.S. Medical Affairs with AbbVie. I've been supporting the venetoclax program now for about 2 years. And today I'm not going to be presenting any data, but I'll be giving you an update on some of our ongoing phase 3 studies. Simply for your education and awareness. It's a little bit about AbbVie. Many of you are familiar with AbbVie, especially as it relates to venetoclax, approved in CLL and AML, with very strong presence in hematology and are looking to expand that in the myelofibrosis. So with that, I'll jump right in. The compound I'm going to discuss today that's being evaluated in myelofibrosis is navitoclax. This is an investigational agent. It's not FDA approved. And so safety and efficacy, of course, are under evaluation. The discussion today is simply intended to share information regarding some of our ongoing clinical trials. Information is only a point for your consideration. It's not intended to influence your clinical judgment whatsoever, but just arm you with, additional knowledge of ongoing clinical programs that may be of interest to you and potentially your patients. All right, so before I discuss our clinical program, I want to just speak a little bit about navitoclax itself. Navitoclax is a very close cousin to venetoclax, which I'm sure you're all very familiar with. It is part of the BCL2 family of apoptotic or rather anti-apoptotic proteins. And navitoclax in particular inhibits BCL-XL and BCL2, both pro-survival proteins. Many of you familiar with venetoclax are familiar with the BCL2 protein because venetoclax selectively targets that. Navitoclax targets both that and BCL-XL. Now in myelofibrosis, we care a lot more about BCL-XL as that is one of the pro-survival proteins that's tends to be overexpressed in both JAK-naive and JAK-exposed patients. BCL2 expression is much lower. in myelofibrosis versus other hematological malignancies. And so navitoclax works in conjunction with ruxolitinib, by basically affecting this cell death pathway in a way that works very well with ruxolitinib. So preclinically and translationally, you're all familiar with the JAK-STAT pathway, and you're all familiar that this is the primary driver in myelofibrosis. What you might not be familiar with is that JAK-STAT also leads to transcription of BCL-XL and another pro-survival protein, MCL1. And this overactive pathway then overproduces these proteins. So what happens when you inhibit the JAK-STAT pathway with ruxolitinib is, in addition to shutting down that pathway and the resultant decrease in production of cytokines and fibrotic growth factors, you also decrease transcription of BCL-XL. And what that means is the cells then are increasingly susceptible to a BCL-XL inhibitor like navitoclax. And preclinically, the company ran a number of studies many years ago showing that if you inhibit BCL-XL in the presence of JAK inhibition, you have a synergistic activity in killing off those cells. You can also overcome JAK resistance in cell lines that have developed resistance when you introduce a BCL-XL inhibitor. So on the basis of these preclinical models, the company started a proof of concept study of 34 patients. And we've presented data on this group of patients multiple times throughout the last few years. Recently published some of that data in the Journal of Clinical Oncology in late February with a promising reduction in spleen volume and symptom score, TSS50, in our group of 34 patients. So I'd encourage you to check out that data if you haven't seen it yet. But based on the promising signal that we saw from that phase 2 trial, company moved forward with 2 phase 3 studies, which I will talk about now. The first of those phase 3 studies is Transform 1. And so I'll talk a little bit more about the study design here. So Transform 1 is a phase 3 randomized, double-blinded, placebo-controlled study. And it's active and ongoing. It activated in fall of 2020. We're still looking for patients. And we're looking for 230 patients total who are JAK naive. So they haven't been exposed to a JAK inhibitor, have primary, secondary myelofibrosis, and they're randomized in a 1-1 fashion to either navitoclax and ruxolitinib with the same dosing schema that we established in our phase 2 study, compared to a placebo matching arm with ruxolitinib as well, and then continued until disease progression or unacceptable toxicity. So a little more detail on the sorts of patients that we're interested in for this trial. These are patients, again, with primary, secondary MF, designated as intermediate 2 or high risk by the DIPS plus scoring system, have at least 2 symptoms with a score of at least 3 or total score of 12 as measured by the myelofibrosis symptom assessment form. They do have to have platelets over 100,000 per microliter. And part of the reason for this cutoff is that we know the navitoclax causes thrombocytopenia in addition to the disease state itself and ruxolitinib. And so we want to make sure that patients, we're minimizing the potential for bleeding risk here. Patients also have baseline splenomegaly defined there. I won't read through it. They can't be candidates for stem cell transplant at study entry. I'd already mentioned that, again, on this particular study, we can't have patients that have any sort of prior treatment with JAK2 inhibitor or other BH3 mimetic compounds or BET inhibitors. And then patients cannot have had leukemic transformation as noted by having at least 10% blasts in peripheral blood or bone marrow. And I won't read through the other exclusion criteria, but I'll leave that for your reference, and there will be a site that I can refer you to at the end with more information on eligibility. All right, so that's Transform 1, our JAK naive study. The second phase 3 study I want to discuss is Transform 2. So the big difference here is that unlike Transform 1, where we're looking for JAK naive patients, in Transform 2, we are seeking those who have had prior exposure to ruxolitinib. I know it says prior JAK inhibitor there, but we're only allowing for prior ruxolitinib on the study. There are 2 other, as you're all aware, there's 2 other JAK inhibitors approved. And in this case, we're looking for 330 patients. So they've had prior ruxolitinib and they have progressed according to IWG criteria, again, with primary, secondary myelofibrosis. And in this case, they will either receive the combination of navitoclax and ruxolitinib, similar to Transform 1, exact same dosing, no differences there, But this time the control group is best available therapy, and it's really investigators or physician's choice of either continuing ruxolitinib, switching to fedratinib, or using another therapy such as hydroxyurea, interferon, or danazol. And then again, patients followed until disease progression or unacceptable toxicity. Some of the eligibility criteria that are different compared to Transform 1, I'd already mentioned the prior exposure to ruxolitinib being the defining differentiator between this study and Transform 1, and some of the criteria are listed in the sub-bullets in the lower left-hand side of that green box. Otherwise, the requirements with regards to platelets, risk category, symptoms are identical to Transform 1. Same with stem cell transplant, patients cannot have been a candidate. I think it's also important to note that patients cannot have received more than one JAK inhibitor to be enrolled on this study. So it can only be ruxolitinib in this case. So if they'd received ruxolitinib and then say fedratinib or potentially pacritinib, they would not be eligible for this study. Here's some of the outcome measures we'll be evaluating as we enroll patients on both of these studies. The primary endpoint is the number of patients who achieve spleen volume reduction of 35% week 24, which is a very common endpoint, of course, as you know, across these studies. And then secondary efficacy endpoints include total symptom score reduction and various measures of response and survival listed there, as well as reduction in bone marrow fibrosis. Importantly, we're also looking at safety, of course, and then various quality of life measurements such as fatigue and physical functioning across both studies. That's a quick tour of two of our ongoing phase 3 studies. Again, they are active. They are enrolling patients across the country. We have 30+ sites for each study in the US. And so if you want more information on these studies, you can visit AbbVieResearchStudies.com and get more information on these two studies and another ongoing study that I did not discuss today. You can get information on eligibility, the current locations. There's a Google map that's embedded that shows you all the current sites. And also connect to the AbbVie team if you're interested in learning more about the study, or if you have a patient in mind who might be interested, who you think perhaps could be a good candidate as well. So with that, thank you once again, Anne, Mallory, and your colleagues for allowing me to discuss our program. I'll stop sharing and pass things to the next presenter. Thanks, everybody.
Thank you so much, Brian. We really appreciate it. Very informative. You know, it always shocks me whenever we go through this, and yesterday was not any different, that we have so much going on in this field, and it's so invigorating. So we will move on to PharmaEssentia and Dr. Ray Urbanski, who's the Senior VP for Clinical Development and Medical Affairs. Good morning again, Ray. Can't hear you.
Hello, how are you?
I'm good, thanks. How are you doing?
Well, I just got done doing a payer presentation for an hour and a half, so I'm better.
Okay, well, thanks for joining us again. And of course, this presentation is for the physicians out there who see MPN patients. So I will let you do your thing.
Thank you again, Ann. So what I'll do over the next 10 minutes or so is just basically tell you a little bit about PharmaEssentia, and then how we approached MPNs in general and then PV specifically. The company really has been focused on MPN specifically and really advancing the science, and then looking at how you can improve the current therapeutics where you're actually treating the disease itself rather than treating disease signs or symptoms. And so I always start with this schematic, and I apologize if it's a little bit simplistic, but I think it helps because I'm going to show this slide again within a couple of slides, just to familiarize everybody again that PV is a trilineage disease, so it's actually going to affect the red count, the platelets, and the white blood cell count. So focusing on just one of these of the three is most likely not sufficient, and recent data has been sort of supporting that. ET is another disease. I think you've heard some presenters speak about that as well. I'll show you a clinical trial that we're actually conducting in essential thrombocythemia, and I'll show you the data that we have from our Polycythemia Vera trial, which makes us feel pretty positive about what's happening, how best remedy can actually impact ET. Myelofibrosis, we are doing some early work, but again, I think you have heard or will hear more about some other colleagues that are on this call also speaking about their studies within myelofibrosis. But keep in mind, as we know, PV is actually primarily caused by a JAK2 mutation in the hematopoietic stem cell, listed here as the pluripotent stem cell. And so that's where the disease is emanating from. So obviously, if you have a therapy that affects the mutated pluripotent stem cell, which is the source of the cancer, therefore, then you actually are treating the disease rather than things that treat it more downstream. And I'll show you a schematic briefly about that. So two things about Besremi. One I just alluded to was its mechanism of action of where it actually works, and then its structure. Besremi is site-specifically monopegylated. So why is that important? Well, the other drugs that you may be aware of, Peg-Intron, Pegasus, are randomly pegylated across multiple sites within the interferon alpha-2A or 2B protein, depending on which drug you're looking at. And that obviously, putting all those PEG moieties will affect its pharmacokinetics, will affect how the drug itself engages with the interferon receptor, its on-off kinetics, et cetera. That has an impact on not only its safety and tolerability, but also will have an impact on its efficacy. And I'll show you some data that sort of highlights that in a moment. So the key point here is that Besremi is unique is because it's site-specifically monopegylated, with pretty much just a pure isoform rather than having 8 to 14 of them, as you can see on the bottom right of this slide. So here's my bone marrow slide. And again, my apologies because it is simplistic, but it just makes it easier, especially for me when I track these things. So Ropeg interferon alpha-2B is Besremi. That actually works at the JAK2 mutated pluripotent stem cell. So it's acting at the disease itself. JAK inhibitors, not selective myelosuppressives like hydroxyurea, actually work further downstream. Hydroxyurea basically inhibits anything that's proliferating at a slightly greater rate, and hence why you have some of the toxicities and tolerability issues you see with that drug. Aspirin and phlebotomy obviously are working in the peripheral circulation to deal with consequences of the hyperviscosity that you see with diseases such as PV. So with that, let me just talk briefly about the actual clinical program we did in PV. And first I'll touch upon the clinical goals that we were dealing with to look at, and then the science and what the science was telling us. And that's how we developed the programs. So when you look at sort of established treatment goals, it's not just treat the signs and symptoms as listed in number 1. It's really not just looking at the peripheral counts, and certainly not just looking at the hematocrit. So we're not just focused on the hematocrit less than 45 or a platelet, but we're also looking at getting the platelet count down and getting the white blood cell count down. You can see some of the publications that have been recently published or presented at meetings such as ASH, which was basically reinforcing the fact that all counts count. And as you can see in the middle there, in a blood article in 2020, that persistent leukocytosis is sort of associated with disease evolution. So obviously, if you focus on just the hematocrit, you may be missing some important risk factors or prognostic factors for poor clinical sequelae or outcomes. Number 3, you certainly want to prevent the thromboembolic events or the disease progression, as I mentioned. So that'd be goal number 3. And then, of course, the ultimate goal is to get a complete molecular remission, which means you look in the bone marrow and there are no JAK2 mutated cells, for example, in PV. And as I showed you with the mechanism of action slide, Besremi is really the only drug that can really do that when you look at other JAK inhibitors, for example, or you look at drugs such as hydroxyurea. So when you have these treatment goals in mind, you know what the most recent data is, and then you look some of the real world data out there. And again, you have hydroxyurea where the CHR is defined as just those 3 hematologic parameters I mentioned. You can look at this 2 ways. You have a 25 to 55% CHR rate, or you can look at the other way around. You have a 45 to 76% failure rate, which is very high. And I'll show you data from our trial that shows how Besremi actually does much better than that. Previous generation interference, so the polypegylated drugs I may have mentioned earlier, had around a 50% CHR rate, or in another way around is a 50% failure rate. And why is this happening? So first of all, some of these drugs are not tolerated. The big problem with hydroxyurea is most of the time you cannot get the patient up to a high enough dose to get their blood counts below the recommended thresholds. And you can see from the REVEAL study, which is a fairly large registry type study, that 73% of patients discontinue hydroxyurea because of adverse events or lack of efficacy. So one would think when a patient's sitting in front of you and you know you have to treat them for years, if not decades, giving them a drug where you think that only 25% of them are going to stay on it for any length of time because of toxicities or lack of efficacy, it certainly wouldn't be the first thing that I think of for treating it. And now you also know that Besremi actually works at the disease source itself, and therefore probably would be more of your drug of choice in that situation. So with the goals that we had for therapy, with the data that we saw that was out there, Besremi was purposely designed to get around a lot of safety, tolerability, and increase exposure to drive efficacy. And this is what we saw in one of our studies. I'll show you another one a bit later. This was a study done over 7.5 years. So again, the length of treatment and observation is relevant, especially in patients with PV. You can see that, we follow 51 patients, 7.5 years. You can see the median years of follow-up, which is fairly substantial. 53% of the patients completed 5 years of treatment. That's relevant because these patients were coming into the clinic every 2 weeks during that whole time period, which just shows you how motivated they were, et cetera, to continue dosing. Patients were switched from Q2 to Q4 if after a year they actually had stable hematologic parameters. We did not see any decrease in efficacy in patients that switched from Q2 to Q4 week dosing. So when we take this trial and we look at the efficacy, here you see it presented two ways. One per protocol, which included the spleen size. And for various reasons, the numbers changed because this is relatively early in the disease state, and the spleen was changing slightly from normal physiologic or measurement errors. And so this endpoint rounded out to be a little bit less, with the overall response rate, CHR rate of 61%, which is still remarkably better than the data I've shown you previously. And then when you look at the hematologic response, so basically just looking at those blood parameters, the things that you're most likely to make clinical and therapeutic decisions off of, the response rate was 80%. Now, again, as you can tell, that it was remarkably better than what you saw when I showed you previously, with just the hydroxyurea or the polypegylated interferons, for example. And then when we look across the all three counts, and we look at it in this way. So here's a line, there's the hematocrit of 45%. You want everybody below that. And then you look at the platelet count and the white count of 410 respectively. You can see, and please note that this is over 370 weeks, which is about 7 years. And you can see that we kept the hematocrit below 45. The platelet count went down fairly significantly and stayed down during therapy. And the white count also went down and stayed down during therapy. Now, I mentioned previously, this is why we're pretty excited about the SURPASS-ET study, which I'm going to show you in a moment. But Besremi certainly has an impact on the platelet count as well. And we feel that this will certainly be seen in the essential thrombocythemia program that we're currently conducting. But this is why we keep on emphasizing all counts count, because other therapeutics may focus just on signs, symptoms, or actually just focus on hematocrit. And we think that's a little bit short-sighted, where you actually have to look and treat the disease at the source of the disease and treat all three counts. This is our PROUD CONTIs, we call it, PROUD PV continuation PV. This study has been updated and presented and published in multiple journals, including Lancet Blood, and has been presented with updates at ASH. This is just one of Dr. Gislinger's slides that he presented at the ASH meeting, and you can see I won't focus on the BAT arm, but if you look at the response rate, it stays around 75 to 80% over the full 5-year observation period. So you get a very deep and you get a very durable response. But most importantly, when we looked at the allelic burden data, so again, this is our way of sort of assessing, is Besremi actually working on those JAK2 mutated cells, which the allelic burden is a measure of. You can see the baseline that the two groups stayed about the same. The green box is the Besremi arm, and the bluish box is the hydroxyurea or best available therapy arm. So they started at about the same place, and over the first couple of years, they both sort of drifted down. But after year 2, you can see that the hydroxyurea bat arm starts going up, and then by year 4, it's above what the baseline was, obviously showing you that it's had no impact on the disease itself or disease progression. Whereas the Besremi treated group, the numbers, actually, the allelic burden went down quite substantially, going down to less than 10% by year 4. And you can see by year 4, around 14% of the patients treated actually had a complete molecular response. And keep in mind, that was like the ultimate goal of therapy in those 4 sort of goals of therapy that I showed previously. So what did all of this focus on treatment goals and treating the disease itself? What did that lead to? So it led to the approval of Besremi on November 12th. So we've been on the market for about 4 or 5 months. It's indicated for the treatment of adults with Polycythemia Vera. So as the FDA said in their press release, regardless of the patient's treatment history, so it'd be first line, second line, et cetera. And then the most recent NCCN guidelines came out in February. And Besremi is recommended both in low and high risk patients. And I'll show you this on this schematic. So you can see that Besremi is recommended in the low risk group along with aspirin and phlebotomy. And so it could be the NCCN guideline committee sort of recognition that ROBEG interferon actually can do some disease modification, and hence it's sort of inserting it rather than just a pure watch and wait with low risk patients. In the high risk patients, you can see that we're listed in first line. Please keep in mind that hydroxyurea and Pegasus, which is the alpha-2A, is not FDA approved for first line therapy. So we're the first agent to actually be approved in first line. Ruxolitinib is approved for second line post HU intolerance, et cetera. So I think that's the last of my slides. That's footnote J. Oh, one last slide. This is the SURPASS ET study. My apologies. So this is the essential thrombocythemia program I mentioned earlier. This is just one of the studies. It's currently being conducted across 7 countries. We have about 100 patients to date. We're looking for 160. It's a second line study versus anagrelide. And we're anticipating the study to complete sometime late this year or early next year. So with that, Anne, I thank you for your time, and hopefully that was helpful.
It was wonderful. Thank you very much. And I would contain the pack of dogs I keep hearing over there. Are they waiting for their supper or
Oh, no. They get fed about 5 a.m. So they're in their mid-morning let's start fighting routine.
Yeah. Oh dear. Okay. Well, thank you so much, Ray. As I mentioned before, if we get questions in, we'll get those to you as soon as possible. And, this is to our physicians, and they typically watch it later, but there are some with us today. So thank you very much.
Thank you, Anne.
So moving along, we're going to talk with Nora Boyer at Protagonist. She is the Vice President of Medical Affairs. Hi, Nora.
Hi. I'm going to share my screen in a moment.
Okay.
Can you see me? Yeah. Okay.
I can see most of you. Your nose, it cuts. There you go.
Can you see
There
me
you
now?
go.
All right. Okay. I know. I was shrinking my chair. So good morning, everyone. And Anne and Mallory, thank you for inviting me to speak to you. Protagonist, as you heard me yesterday, it's a small biotech company. We're located in South San Francisco Bay Area, and our technology is based on peptide technology. I have a slide. My next slide here just shows you our pipeline, and it also shows you we're also in some GI, like ulcerative colitis, but I wanted to show you the breadth of our peptide technology. And our lead compound is rusfertide, which is a hepcidin mimetic. And this is our proposed mechanism of action, this slide. And so on the left-hand side, you can see how ferroportin portals allow iron to get into the circulation, into the bone marrow. And if you don't have hepcidin to block that ferroportin portal, that's when the red blood cells will reach the bone marrow, and you'll have an increased hematocrit. Hepcidin, I always say, is probably our rusfertide is the easiest drug I've had to work on so far, I understand, because it's a mimetic and it just simply binds to the ferroportin portal. It closes it through endocytosis. It's taken in, and through proteolysis, there's degradation occurs. And so now all of the red blood cells get into the circulation and reach the bone marrow, and therefore we can keep the hematocrit down. Our phase 2 trial, which is the next schema that I'm showing you, was 60 plus patients. The main goal was to maintain a hematocrit below 45%. And based on the success of this trial, the FDA has allowed us to move into phase 3, which we just initiated our first few sites this month. And we actually have received breakthrough status. I'm going to show you a few slides from that study to show you the impact that rusfertide has on phlebotomies. So in the far left, you'll see all these little red dots, and those all are the number of times patients have had to be phlebotomized, and they had to have had 3 or more phlebotomies in the 6 months prior to starting on our trial. And then, as you see, once they started therapy, that number significantly decreased. As a matter of fact, the p-value is less than 0.001. So the decrease was substantial, and that was for patients that were just on phlebotomy alone, or for patients that also were receiving cytoreductive therapy. I'll show you on the next slide. Again, it shows that the hematocrit, it kept it within a normal range, and the RBC count was also kept within a normal range. Also, you can see that almost immediately within 4 weeks, we saw a normalization of the iron stores, the MCVs returned to normal, and the TSAT went back to normal. So demonstrating that rusfertide is able to increase and keep, while keeping the hematocrit low, also keep the normal iron stores sufficient. This is the improved MPN treatment scores, and you can see that rusfertide increased or decreased the level of fatigue, decreased the itching or pruritus, and also improved concentration. And this next slide is the patient global impression change. And you can see the 71% of the patients perceived an improvement at 9 weeks. So with all of this, this moved us into our phase 3 trial design, and we're calling that Verify. And here are some of the criteria. They have to be adults. Of course, we're not doing this in pediatrics, and have PV according to 2016 WHO criteria. We are accepting high and low risk patients. Patients have had to have frequent phlebotomies, again, more than 3 in the previous 6 months starting the trial. They can be with or without cytoreductive therapy. And the only thing that we are really, the main exclusion is that patients cannot have had an invasive carcinoma in the prior 5 months. The primary endpoints will be absence of phlebotomy, eligible based on hematocrit control between week 20 to 32. We'll also look at secondary endpoints of number of phlebotomies, symptom improvement scores, and safety, and of course, the durable response. This next is the treatment diagram, and so you'll see patients will be randomized and double-blinded placebo-controlled study. We're calling this a Verify study. There will be 250 patients, and it will be a global study. Patients will be randomized to either rusfertide plus ongoing therapy, or placebo plus ongoing therapy. That will last 32 weeks. And then at 32 weeks, we're going to do a primary endpoint evaluation. We'll unblind it, and then everybody will be able to go on to rusfertide plus their ongoing therapy. And you'll see that the end of treatment was out to 156 weeks. So that is all I have to show, but I welcome any questions. You know, at this point, rusfertide is our lead and only compound for PV. So Ian, thank you very much. I know I didn't take my 15 minutes.
That's okay. You know,
I don't have much more to say.
But we thank you. This was very informative. And as I said, our physicians that are with us, I think are just keeping track of everything. And then those that will watch this later may have questions and may reach out to you personally or to us, and then we will reach out to you as well.
Oh, you're welcome. And
But
this
this
is
information is really important for them in terms of sharing with their patients. And yesterday, as you know, we did this for patients who will share this information with their physicians, which it works really well. We know that for sure. So
Well,
thanks so much.
Thank you, Ann. And it is on clinicaltrials.gov, so it is open.
Yes. And
Great,
it is
thank
on
you.
our website as well. Yep, good.
Thank you.
Thank you, Nora.